it's live here, but it's not live on YouTube yet. So I'll let you know once it's almost open on YouTube, and then we will be able to start. Okay, seems like it's open on YouTube now, so I will remove myself and our speaker, and then when it's time, I'll put her back on the screen.
Amanda, I may need you to do the prayer if Livia's microphone doesn't work.
Okay. Oh God, the prayer is not in the script, Chia. I'll have to make it up.
Yeah.
YouTube now, so okay, we are live on YouTube, and so we can get started.
Okay, we are live. Good evening, everyone. For those who don't know me yet, I'm Sonia Doi. I'm a physician and the current president of the U.S. Spiritist Medical Association that we will refer to as SMA. And on behalf of the SMA, I'm excited to welcome all of you to the second webinar of the series, Spirituality in Mental Health. And I know we have at least 4 participants in Brazil, and they are 2 hours ahead of us. So I want to thank them very much for staying late to participate in this event. Tonight, I have the pleasure to have with me Dr. Livia Uehara and Amanda Soto. Dr. Uehara is an MD and is specialized in internal medicine and hematology. She's the vice president for the SMA. Livia will say a prayer and introduce our speaker for tonight. She's having some problems with the microphone. If she cannot fix that, Amanda will do so. Amanda holds a degree in MPH and is a member of the SMA. She will join us also at the end of the talk to handle the questions in the Q&A session. For those who are not familiar with Spiritism and with the SMA, I'll give you a brief introduction. Spiritism is a science supported by empirical evidence, I'm sorry, and is a philosophy based on the moral teachings of Jesus. The main tenets of Spiritism include the existence of a supreme intelligence, immortality of the soul, reincarnation, mediumship, and plurality of inhabitant worlds. It's also important to mention that Spiritism is open to all beliefs and religions and has no discrimination whatsoever, including to race, gender, ethnicity, or culture. The SMA US is a nonprofit organization directed by Spiritist medical doctors, and its main objective is to support spirituality in healthcare, aiming to treat the body and to heal the soul. The SMA US works by organizing conferences, webinars like this one, and publishing articles online. You can support our cause by becoming a member. There are 3 membership categories: the healthcare professionals, students, and non-healthcare professionals. In summary, anyone can become a member and support us. The link for membership is pasted in the chat box. Members of the SMA are entitled to a discount fee in the webinar registration and will have a free access to a new activity that we're going to start probably in March called Spirituality and Science in Discussion, in which a panel will discuss scientific publications of interest, and the audience will have a chance to interact with the panelists through the Zoom platform. The webinars on spirituality in mental health will be held continuously bi-monthly through the whole year of 2023. And tonight we are delighted to have with us Dr. ELAINE DRYSDALE. But before we introduce Dr. DRYSDALE, I'll ask Livia, if her microphone is working well, to lead us in prayer so that we are all involved in a serene and conducive atmosphere. Livia, how is your microphone? I don't think. Livia? Is your microphone working?
Can you hear me?
Yeah. Can you lead us in prayer, please?
Can you hear me?
Yeah.
Yes, yes. I hope you all can hear me. Good evening, everyone. I would like to invite you all for a minute of introspection, just to focus on yourself right now. If you feel comfortable, close your eyes and connect to yourself. Initially, then visualize that you are inside of a room together to all of us. And connected to higher power, the nature. And we ask for that power to inspire us tonight to be together and to learn to DRYSDALE.
Thank you, Livia. I think your audio is still failing.
My audio is not working well.
May I ask maybe Amanda to read Dr.
Can you hear me now?
Let me ask Amanda to do it because
Dr. DRYSDALE's
yeah, because your microphone is failing, Livia.
Okay. So very pleased to introduce Dr. ELAINE DRYSDALE, who's a physician who attended who received her Bachelor of Arts in Psychology prior to her medical degree. Following medical school, she's specialized in psychiatry. She's currently a clinical professor at the Faculty of Medicine at the University of British Columbia. Dr. DRYSDALE has worked as a psychiatrist in various medical settings, including over 25 years as a psychiatrist to the Leukemia Bone Marrow Transplant Program in British Columbia and to the British Columbia Cancer Agency in palliative care programs. She has given numerous lectures at both national and international professional settings on several topics, including psychiatry and cancer care, bone marrow transplantation, and near-death experiences. Dr. DRYSDALE co-led a weekly supporting group of breast cancer metastatic patients for 6 years, helping women live fully while coping with dying. She's been asked to give eulogies at many of the 35 funerals of the group members, which she has considered an honor. She's had an interest in near-death experiences for approximately 30 years and has used these experiences in treatments of suicidal patients, as well as having taught about near-death experiences to patients, grieving families, physicians, and other healthcare professionals. She believes that awareness of near-death experiences provides a hope-filled new paradigm for many patients in coping with the anxiety of a life-threatening illness. In 2018, Dr. Drysdale talked in the Congress of the U.S. Spiritist Medical Association in Miami, and has since that time spoken at various Spiritist events. Thank you, Dr. Drysdale, and I'll now pass it on to you.
Well, thank you for that lovely introduction. It was a very full one. And I'd also like to thank Dr. Sonia Doi for doing such a magnificent job of organizing these webinars, but being so involved at the national and international levels of promoting spirituality and in the medical care. So thank you so much, Sonia, and thank you for inviting me to speak. So what I'd like to talk about today is spirituality in guiding clinical practice in mental health issues. And just a brief mention about how things have changed. When we look at medicine in the 1800s and early 1900s, it was viewed very biologically. There was a biological problem and a biological solution, such as an antibiotic or surgery. In the 1980s, mind-body medicine became more popular. And at that time, there was a lot of interest in using biofeedback and in looking at the psychological aspects of pain. I remember Joan Borisenko's book came out, Minding the Body and Mending the Mind. And there was increasing interest in religion in health and illness. In the last couple of decades, there's been more interest in spirituality and looking at non-local consciousness, such as remote prayer and near-death experiences and what they suggest to us about the nature of consciousness. Well, I'd like to get back to brass tacks and looking at spiritual factors. Are they necessary or relevant in medical care of patients? Well, I'll give you an example. One of my patients was a top-ranking executive in a large medical organization. She was given a life-threatening diagnosis of acute leukemia that required extensive treatment and a stem cell transplant. And she said to me later, the spiritual and emotional aspects have been huge in my illness. Everything was affected. I was absolutely overwhelmed by and constantly preoccupied with the fear of dying. So, looking at her care retrospectively, is her fear of dying relevant? Absolutely. And how would you help her cope with the fear of dying? These are some of the real life issues that have confronted me in my medical practice. And I wonder what thoughts you have in hearing them, how you would respond. A despairing, isolated young woman, Jennifer, overdosed, suffered brain damage, and was being moved to hospice. Her father asked me, what should I say to her as she goes to hospice? Later, after she passed away, after her transition, his words were, my faith seems only theoretical. Can you help me in my grief? Another patient knows she is dying. She is worried, is atheist, and states, I don't believe in religion because I believe in science. What can I say to be of help? And then recently, a medical specialist, a friend, called me and said, my cousin is terminally ill with cancer. She's frightened and not religious. What should I say to her? How do I broach the topic of an afterlife? So those are stories of real life and fears of dying. But I'm also confronted at times with real life and fears of living in patients, suicidal patients. How would you respond to these patients and friends? Allison, whose son committed suicide and whose husband has since left the marriage, and she wonders about her life purpose. This is a chronic struggle for her, and I have to come back to spiritual basics with her frequently. George, whose daughter died of an overdose and who has suffered tremendous medical illnesses and who has trouble finding joy and moving through his grief. Felicity, who's been chronically suicidal. Then there is the young mother of 2 young daughters, 5 and 7, who has been suicidal from depression associated with her chronic medical condition. A young father with relapsed leukemia and an 8-year-old daughter who wanted to end his life to have control over his death. So we see people with issues of lack of life purpose, lack of a sense of meaning of life, and who wonder about the value of their relationships. So those are some of the people that have come across my path in the hospital or in clinical situations. But beyond the hospital walls, we all have friends and relatives with questions. For example, Paul, stressed because his father across the country was ill. He didn't know how long to delay the visit, and he had absolutely no idea what he should say. Then Ian, who received the following text one day from his friend Bill, out of the blue. My cancer has returned since last fall when we talked. It has spread and I'm in palliative care and I'm actually being transferred to hospice today. And they say I probably won't live more than a week. Can you visit me and pick up some sushi so they could share a last supper of sushi? What a shock for each of them. Ian wondered what he should say. It was totally a shock. So these are situations in our daily life that we can experience, not just in the hospital. So I'd like to move on now to talk about how do I incorporate spirituality in practice? Well, the first thing is to create an awareness of spirituality so the concept becomes habitual. In medicine, we often talk about the biological, psychological, social model, but we must change that to the biopsychosocial spiritual model with all of those factors. And again, I'd like to thank Sonia Doi for doing her part in promoting this. Now, Dr. Christina Puchalski is a physician in Washington area, and she has developed the FICA model for asking questions about spirituality, and many of you may be familiar with her model. I've attended a workshop with her, and it was excellent. Then there's also another model, the HOPE model, which was developed by some Canadian physicians to guide spiritual assessment in medicine. That's the reference on the screen. And it's very simple. You just remember the letters HOPE. H stands for sources of hope, meaning, comfort, strength, what gives a person strength. O stands for organized religion. P is personal beliefs and practices. And E stands for effects on medical care and end-of-life issues. So these are just simple, it's a simple framework. So you can think of H and say to someone, well, what gives you hope? What gives you a sense of strength and sustains you? What gives you comfort? Do your beliefs give you comfort and strength? If not, did they in the past? And what happened? Why did that change? O stands for organized religion. Are you part of an organized religion or faith community? How important is this to you? What aspects are helpful or not so helpful? P, do you have personal spiritual beliefs that may be independent of the organized religion? For example, a person who may be Christian but very interested in reincarnation, which may not be in the central dogma of much of Christianity. So that may be a more personal slant on it. You might ask a person if they believe in God or a higher power, what kind of relationship they have with God. And P stands for practices. Do you have particular spiritual practices that are helpful, such as prayer or meditation or perhaps hiking in nature or listening to music? E stands for effects on medical care. Has your situation medically affected your ability to do the things that usually help you spiritually, and vice versa? Do your spiritual beliefs affect you? The healthcare situation or decisions that you make in that area? Has your medical condition affected your relationship with God? Are there specific issues that the healthcare team should know about in providing medical care, such as diet restrictions or use of blood products. As a doctor, is there anything I can do to help you access resources spiritually? Would it be helpful to speak to someone from spiritual care? And then E stands for end of life as well. How do your beliefs affect the kind of medical care you would like me to provide over the next few days, weeks, or months? And this has become a real important area with medical assistance in dying, which has become legislated in Canada and in various states and countries. And so the person's spirituality plays a marked role in that. When we look at end-of-life issues, major themes that I've come across are fear of abandonment by God or people, isolation, fear of the unknown is a big one. Wanting to be in control of the future is a very big one, and I think plays a big role in requests for medical assistance in dying. Then there are anger and fears about imminent death, in addition to grief about life ending. So those are some of the questions that you can ask to get a sense of what might be helpful to the person. But if the patient is nauseated or in pain or dying, sometimes it's too much effort to go through that for the patient, and I cut to the chase. And I just ask, do you believe in a spiritual realm or in God or higher power? Do you believe in an afterlife? Those questions are simple, but useful to provide support, especially if the patient has a life-threatening illness. It sounds obvious, but these questions are often missed or considered to be too private, which seems to me to be a bit crazy when the patient is facing a life-threatening situation. But sometimes health professionals just don't know how to respond. But you don't need to be a chaplain or a part of a medical team to be able to ask some of these questions. Now, as a physician and psychiatrist, of course, I have to ask some other questions, particularly regarding mood and thought content. And it's interesting that symptoms of depression can include a lot of thoughts of guilt, persecution or being punished, low self-esteem, and even loss of faith. And on the other hand, symptoms of mania or being really speeded up, people can become hyper-religious and with sometimes very bizarre religious content in their thinking, and they can have increased intensity and zeal. So such themes can reveal mood disorders and or spiritual challenges, or both, which is very interesting. We know that there have been studies on how faith can affect mood, but I believe that mood also affects faith. And when I see people that are depressed, they often lose their faith. And when their depression is treated, their faith comes back. And on the other hand, people, when they're manic, as I mentioned, they can their faith can change directions in its content. The role of mood may be missed if you look at some of these ideas from solely a religious perspective. That's very important. I've given talks to different church groups and where depression was actually missed and people felt they weren't being spiritual enough. Now, these are some common themes I'm going to talk about from my personal clinical experience with psychiatric areas, inpatient, outpatient, and emergency department areas, and also on medical wards with people with life-threatening illnesses, and also from my group therapy with cancer patients. Now, all of these things that are on the screen, the next few screens, are things that have come across my path clinically. I didn't read them in books. They were just, they were different ideas that patients presented with. I found that some people were actually, it was like they were vaccinated against religion because they'd had too much meaningless ritual. They'd had enough to turn them off for life. Others had backgrounds that there was very little religious exposure, or it was so wishy-washy, it didn't really take. And so later they felt uncomfortable in religious situations and avoided funerals or religious services. Then there's some families have been hostile to religion and it can produce a prejudice against religion. In some families, there's a lack of spiritual mindedness or psychological mindedness, and so that can result in a paucity of inner resources or coping styles. Some people have grown up with a punitive father, and that can result in projecting those qualities onto God, and God is then viewed as being a very angry creator. And some families, there is a lack of teaching of forgiveness, and that can result in resentful attitudes and a get-even mentality. Now, when people get sick, other spiritual factors come into play. There may be loss of meaning in life, or people say, why me? And other patients have said to me, well, why not me? I guess it could be me as much as anyone. So people have different responses. Some people feel abandoned by God or angry at God, and then they avoid praying or going to church. Some feel punished, sometimes generally or for a specific sin. And as I noted, depression may intensify feelings of worthlessness or low self-esteem or the perception of being punished. There may be theological differences with other people in the family regarding the role of prayer or differing opinions from pastors. There may be fears of dying. Sometimes the sudden confrontation with mortality is a huge shock. There may be questioning and anxiety about an afterlife or fears of judgment or punishment in hell. Fear and grief of leaving loved ones and of leaving one's life. Fear of separation from loved ones after death due to differing beliefs, such as one woman who was afraid that she would go to heaven, but her husband would not because he didn't share the same beliefs. And then there are fears of being forgotten after death or being replaced. And often that's not discussed with family members, but it's very much present. What are some of the factors that can perpetuate the issues? Well, there may be unresolved faith issues. There may be such discomfort or hostility to spirituality that it prevents the person from reaching out. There may be avoidance of the topic of dying, and there may be pre-existing phobias to the topic of death. I had one patient who refused to ever watch a television show or about death or go to a funeral, and she ended up in palliative care. She was in her 30s. The day before she died, she said, well, when I get out of here, I'm going to date that good-looking nurse. So she had a phobia to the topic of death throughout her life, and she held on to that right to the end. So we've talked about some of the common spiritual themes, but what about the more mystical spiritual experiences? What's the best way to open dialogue about visions, near-death experiences, out-of-body experiences, shared death experiences, or other spiritually transformative experiences? Well, Dr. Lauren Belge is an ICU specialist, and she found that the most important question to ask was, did you experience anything unusual during your medical care or that time that you were comatose in the ICU? Did you experience anything unusual? And in asking that, she would open up many more responses. So I ask patients that, but I say, just a minute, before you answer that, I'm going to clarify a few things. As a psychiatrist, I know that people can hear or see things for many reasons. People have visions for many reasons, sometimes because the brain is ill, and sometimes for truly spiritual reasons. I certainly don't think that all visions, voices, or messages are a sign of illness. And of course, the opposite is true. Sometimes they can be a sign of illness. They can be either illness or they can be valid spiritual phenomena. So that is how I frame it. And so then I say, now that you know that, and I don't necessarily think it's all illness, has anything unusual happened to you? And it's amazing how people will open up if they feel that you're willing to listen. One of my patients said, well, now that you ask that, I want to tell you, the night before my transplant, a huge angel appeared at the foot of my bed. She was luminous, and she had these huge wings, and I could see every feather on her wings. It gave me such peace and comfort. This has never happened to me in my life before. After that happened, and after I got home, I drew a picture of her. So this patient agreed to bring the picture to show me, and I asked her if she would mind if I shared that in a talk and made a slide of it. So I'm very grateful for her having done that. But what's interesting also is that since this, I've become aware of this and I've been open to it. Other patients have also told me about the transplant angel that wanders around apparently on the 15th floor of the transplant unit of the hospital where I work. So I'm just going to take a little detour here for a moment on that topic. If there is a spiritual realm, why can't we see it? And some of you may have heard me talk about this before, but it came to me that the magic eye books that were very popular in the 1990s are a really good analogy for maybe looking at the spiritual realm. The magic eye books are books that have pictures that are all dots, and as you can see in this slide, there's just a sort of a sea of green and red dots, and you put the picture right up to your nose and then stare through the page and pull the book slowly away. And as you do that, there's a sweet spot of a focal point, and suddenly you can start to see the patterns that are the actual picture that's embedded in what seems to be a sea of dots. And it's the same picture for everybody. It might be in one of them, it might be seals bouncing balls on their nose, or it might be circus animals or a flower scene. It's the same for everybody, but it can only be seen at a certain focal point of your eyes. And it occurred to me one day that this might be a very good analogy for why some people can see visions in a spiritual realm. We know that small children can often see spiritual beings until they're age 3 to 5. But I think we need to adapt to living in a physical world that needs boundaries for physical objects. We need to know this is a real table, a real chair, and that the people nearby have physical bodies. Otherwise, we could be at risk for harm. So perhaps at about age 3, as the child adapts to the physical world, needs to know the boundaries of those material objects. And so the focal point becomes more hardened to that of the dense material world. And perhaps the ability to flexibly move one's focal point visually is lost for seeing that less dense spiritual energy. But we know that when people are dying, or in the last sometimes year of their life, it's not just in the last hour or two, it can maybe be months before, that focal point seems to soften again, and they may be more able to see a spiritual realm. Now, Dr. Jeff O'Driscoll is an emergency physician, and he worked in emergency for many years, and was able to see sometimes the spirits of patients who were not able to be resuscitated in emergency. And he has come out about this and written a book called Not Yet. And he talks about the veil, and he says it's as if there's a curtain and that it parts when newborns come from that spiritual realm more and into the physical realm, and it parts again when people are leaving, and that the light of glory is more visible as that curtain is opening. And it seems to me that it's more visible perhaps to people nearby physically, or perhaps emotionally close to the person. And I wondered, are there certain frequencies in certain areas of the brain that make this more likely to happen? Now, just as a quick aside, there's been a whole paradigm shift in how we view consciousness. It's becoming more apparent to scientists that the brain does not create consciousness. The brain is just the hardware, like the TV set for the consciousness, which is the program, the software. And so our physical bodies and our brain, we're just the hardware for it. But consciousness actually exists beyond the brain. And furthermore, the brain appears to act as a filter. We know that when people have had cardiac arrests, the longer that they've had the arrest, the more expansive their consciousness is if they've had a near-death experience. And with the thinking is that without a filter, we would be overwhelmed with cosmic information. And so we only need information that helps us to survive in the physical realm. So our brain actually filters out tons of energy. And you can think of that as light waves or sound waves. We only get a small band of frequency that our brain can deal with. So I'm going to move now from assessment and philosophical possibilities to how to respond in an actual clinical situation with your friends. What would you say to Ian to help his dying friend Bill at hospice? Well, what did I say to him after praying for help, for divine guidance? And I'm just going to read this to you, and you might want to close your eyes and just listen. I asked Ian about Bill's beliefs, and he knew that Bill had been a devout Christian. In response that evening, I texted this to my friend Ian, and I have permission to use this verbatim. And because I knew Bill was Christian, I tailored my response with that in mind. I hope it goes well. This is what I wrote. I hope it goes well with your visit. I'm sure you will cheer him with your past memories together. I could imagine them laughing about some stories. And you might cheer him with the impact on your life. And you might tell him about my work with people who've had near-death experiences, who've come as close as you can get to the other side and still be able to come back and talk about it. And these people are so overjoyed on that side with celebrating and reconnecting with beloved friends and family. And because he was Christian, I added, some have described seeing Jesus personally. Many Christians have had these experiences, and some have reported seeing the New Jerusalem as described in the book of Revelations, with crystal buildings and with gemstones and colors. Amazing. Beautiful colors, meadows, and flowers. Sounds wonderful. And please tell him that I enjoyed meeting him that time several years ago. I appreciated his gentle, elegant energy. Well, good luck. Well, Ian arrived with sushi the next day, which was totally savored by Bill, and they shared many laughs, and Ian told him how much he had appreciated him over the years. And then Ian said, I received this text from ELAINE this morning, and I'm going to read it out loud, exactly as she wrote it. So it was as I just read to you. When he got to the part about celebrating and reconnecting with beloved friends and family, Bill put his head back, closed his eyes, and had a huge smile. And then tears started streaming down his face, and that huge smile continued. My friend also started to cry, knowing that he had touched onto something that seemed to be very powerful and healing. What I hadn't known when I wrote that text was that Bill's daughter had died unexpectedly many years ago. You know, this is the amazing thing when you ask for divine help, you know, in helping people, because we are accessing a greater wisdom than ourselves. And so the right words can come to be helpful. And I've always found that asking for help is what makes the difference. So, and I hadn't known that Bill's faith had been shaken for many years after his daughter's death. The vision of reconnecting with his daughter likely triggered those tears of apparent joy of seeing her again. And the references to his faith were helpful. Bill said that his faith had wavered and changed, but he could relate to what was being said, and this was helpful. It reinforced his faith. Apparently, both Ian and Bill laughed and cried, and then Bill asked Ian if he knew what it was like to die, since Ian had been with a family member as she had died. Ian said that what he had seen up close was a peaceful ebbing of awareness and stopping of breathing. But as he had heard me talk about NDEs, he elaborated on what he had heard from me to Bill, and that regardless of what it looks like on the outside to others, people who have come that close have said that it was incredibly peaceful on the inside, and it felt very orderly, and they felt surrounded by love. Bill found this knowledge to be a relief. Ian left, feeling that he had been part of some divine intervention for his friend, when his friend needed encouragement the most and was afraid of dying. Ian said that watching Bill relax with eyes closed and such a smile and tears streaming down his face with joy was so moving. So, on reflection, I felt grateful that my simple little text, read to someone I didn't really know, and when I wasn't even there, could be so helpful. I couldn't really take credit for it because I had asked for divine inspiration at the time. On reflecting about what had been helpful, I wrote down the following: acknowledging that the person is important and not delaying actions, and actions can speak louder than words. Having joy and laughter is important, and maybe even sushi, right to the end of life. Nobody wants grim faces around when they're alive, nor when they're dying. For 6 years, I led a weekly group for women who were terminally ill, part of a research study held in 7 centers in Canada and published in the New England Journal of Medicine. The women made a commitment to attend until they died. I learned so much from those women of courage, of helping one another. But what was really striking was the amount of laughter, as well as tears that we had in that group. But much laughter. And, I'd like to also add that even though my practice is largely with people with life-threatening illnesses who are very worried or palliative care patients, that often you would be amazed how much laughter there is coming from my office. I've had other people comment on that often it starts with laughter and ends, and there's laughter at various times, which is surprising to people. One of the oncologists I work with, he also has jokes with patients, and they love seeing him because they know that it's not all going to be doom and gloom. One can share memories together, favorite memories, especially good times, letting the person know of the impact that they have had on you. Perhaps, as I suggested with Paul, who was going to see his father, asking the person if they've had unique perspectives or memories to share with you. Perhaps a loving perspective that only the dying person would have, such as a dying father for a son when he was young. So Paul did ask his father, what kind of things do you remember about me when I was little? And so he treasured that after his father had passed on. There can be hope also for a peaceful passing, possibly hope for another realm depending on the individual and all that might entail, including hope for a celebration, a reunion, beauty, perhaps reinforcement of beliefs. A reminder that they won't be forgotten or will leave a memory. Finally, from this story, we are reminded that words are powerful, so powerful to give hope and encouragement, and to nudge the imaginations and creativity of others in a positive way to give emotional relief when it is needed the most. So you can give hope to others. You don't need to be part of a healthcare profession to provide hope. As a healthcare provider for several decades, I wish to share some clinical stories and tips I've learned through clinical and life experience to apply the wisdom of near-death experiences to help others, whether in a medical or non-medical setting. I'd like to note, though, that there is a professional dilemma of sharing faith. Now, Spiritist individuals might feel confident in their own beliefs, but others might not feel so confident. And patients might resent the slightest hint of proselytizing. It's a fine balance between sharing one's faith versus the perception of pushing religion or theological ideas. Even in talking about near-death experiences, which I'm going to talk about in a minute. And some health institutions may have definite policies or constraints against any perception of proselytizing in the healthcare setting. I think that's more so in Canada than in the United States. So I want to talk a little bit about near-death experiences, which are experiences that people have when they're comatose and yet they're conscious. They look to be comatose. Now, these are valid clinical phenomena, and they provide a conversational bridge from the clinical to the spiritual. So we can't always talk about direct faith issues. We can talk about the experiences that other people have had. Discussion of this with a patient is not pushing religious dogma, but providing valuable information about the experiences of others. Discussion of near-death experiences can open the door to discussion of various spiritual topics, such as fear of dying or problems with living. Near-death experiences, by the way, are very common. They occur in 5% of the population, but people just don't want to talk about them because they consider them to be private. When you think about that, that's like 15 million Americans. Now, what I say is that talking about near-death experiences is a way to introduce the topic of death and reduce the fear of dying, or to introduce the possibility of a spiritual basis to life in a way that's intriguing and hopeful. So what I say to a person is, have you ever heard of near-death experiences? You know, what we know from people who have come as close as one can get to dying and still have survived to talk about it is that the actual moment of dying is peaceful to the person dying, regardless of what it might look like to other onlookers. And beyond that, it raises the possibility of a spiritual realm. You may choose to accept the spiritual possibilities or not, but we do know that the moment of dying is peaceful. Would you like to learn more about this? I'll say to the patient. Well, information I can give you is, what is an NDE? Do medical experts believe in them? I've heard that there are medical reasons that could explain these experiences, such as delirium. Is that true? That's what one patient said. Can't it all be explained by the biology of the brain shutting down? How can some people see a spiritual realm? We've already talked about that. Well, a near-death experience is a profound psychological event that may occur to a person close to death or who is not near death, but in a situation of physical or emotional crisis. Sometimes in an accident just before the car crashed, people have had these experiences. Being in a life-threatening situation is not the same as a near-death experience. Like the person that said, oh, I had a near-death experience. I was standing on the sidewalk and a car went roaring by and it could have hit me. Well, that's not a near-death experience. That was a dangerous experience, but not a near-death one. A near-death experience is it's a pattern of perceptions, and it involves transcendental and mystical elements. It's a powerful event of consciousness. It is not mental illness, as described by the International Association of Near-Death Studies. Simply described, it's the experience of increased consciousness when the person appears to be unconscious or clinically dead. They're very common, as I mentioned, in 5% of the general population and in about 18% of resuscitated cardiac patients. A little bit about the history. In 1975, Dr. Raymond Moody, who had an MD and PhD, reviewed cases of 150 people who had experienced these phenomena. They'd had cardiac arrests and were resuscitated, or they were in an injury and came very close to death, and he listened to experiences of people as they died that were reported by the surviving relatives. He wrote about it in his book, Life After Life. In 1975, it became a bestseller, and it was featured in Reader's Digest and influenced the movie industry, and that really opened things up, and it resulted in a changed worldview about dying. These experiences were much more common in the 1960s because that's when CPR, cardiopulmonary resuscitation, became popular. Dr. Moody outlined that a near-death experience can contain some or all of about 9 elements: a sense of great peace and absence of pain, and then an out-of-body experience where people might report a sensation of rising up and floating above the body and watching events below them. And sometimes people can later accurately visually describe the events in the resuscitation room or in rooms beyond from a high vantage point, perhaps a ceiling, and they can report conversations that have occurred down hallways or in other buildings that have been later proven to be exactly correct, word for word. And this occurred when they were comatose. Sometimes people experience a sensation of going through a tunnel, perhaps at high speed, until they see a beam of bright, radiant light at the end. Some people do not report a tunnel, but they rise suddenly into outer space and see the Earth as it would be seen by astronauts. Dr. Carl Jung had this experience long before satellites. Now, sometimes people will be met by deceased friends or relatives who greet them, even when the person who's comatose had not known that the deceased friend had died. And they say, "What are you doing here?" They're surprised. And then when they return after they've been resuscitated, they say, I met so-and-so over there. I didn't know he died. And they said, yes, he died recently, and you didn't have that news. So, and it's interesting that the people that greet the person are always deceased. It's not something that the subconscious mind has cooked up, and that they're just people who are important to the person, but who are still alive. They're always deceased. So they're in another realm, and they often glow with an inner light. Often people are also met by a being of light who's perceived as being loving, omniscient energy, and who is identified as God or Jesus or another spiritual being. Then people often are presented with a panoramic life review in which the person watches his life unfold like in a movie. One person said it was like being in a 360-degree movie where you look all around the room and you see your life unfolding. Another person, Dr. Mary Neal, said that it was like scrolling through pictures at the bottom of her iPhone, and that she would see all these pictures of her life, and then Jesus would say to her, would pull one out and say, let's look at this. And she would be able to see that in detail and see the feelings that her acts created in other people. So the dying person may have a realization that it's the acts of love, even though they're simple, that are of the greatest value in one's life on earth. They see themselves doing something, and they see the feelings that other people experienced. Often the dying person might be told then that he must return to life as it's not yet time for him to stay. But often the person doesn't want to come back to earth. It's so beautiful. Some individuals are given a choice, but they choose to return in order to help loved ones. Other elements that can occur are intense emotions, heightened perceptions of intense colors, beautiful landscapes, a life knowledge of the nature of the universe, a sense of oneness, a sense of having knowledge of the future, or messages regarding the person's life purpose when they return. Some people only have one or two of these elements, but there's similarities across age. Young children have had these experiences. A 10-month-old crawled up the tunnel, and one child thought that the being of light was Santa Claus. But these near-death experiences are similar in individuals regardless of their age, young or old, gender, their education level, and their religion. They've been experienced by people from every religion, as well as by former agnostics and atheists. Now, since Dr. Moody's book, many psychologists and physicians and others have written about near-death experiences. And this is a list on the screen of various, primarily physicians in this list, and psychologists and nursing people, what they have written. I'd like to bring attention to the International Association of Near-Death Studies, or IANS, that has encouraged research in the field and has an annual conference. So there have been many attempted medical explanations. People have said, well, maybe it's delirium from sepsis, or psychosis, or hypoxia, or maybe it's a substance that did this, or maybe it's the DMT molecule or a temporal lobe seizure. But in fact, there are many differences. It's not delirium. They're very different from delirium. And I've talked about this in other presentations. I'm going to kind of zip through this right now, but delirium is an altered functioning of the brain, and it causes a fluctuating disturbance of concentration or attention and of awareness. People become disoriented. It changes, it fluctuates. There's changes in their thinking. There may be hallucinations, very muddled or confused thought processes, crazy ideas, and thoughts are not processed well. The person may be kind of agitated, They may have fragmented sleep, and their emotions are rapidly changing. They may be perplexed. So that's what delirium is. But a near-death experience is very different, and we can explain the cause of a delirium, but we can't explain why being in a state of cardiac arrest would create a near-death experience the way it does. And we can't explain why dreams of dying can create similar experiences as near-death experiences, or why impending trauma without the actual illness can create the experience. So skeptics might try to attribute all features to biological explanations, but some things we can't explain biologically, no matter what biological cause you look at. Delirium is different with partial awareness. Near-death experience, there isn't the awareness. Delirium, there's very muddled, fragmented thinking. Whereas in a near-death experience, the experience is coherent. It may sound fantastically imaginative, but it holds together in a very congruent way. In thinking, the delirium, the content's often distressing, fearful, paranoid. It's never been inspirational. I've seen delirious patients for over 30 years of practicing psychiatry in hospitals, and I've never heard of an inspirational delirious event, not one. And they're not usually about being loved or valued. Whereas in near-death experiences, the content is overwhelmingly inspirational, with a focus on being understood, valued, and loved. So I'm just going to zip through a little bit of this. Another major difference is that there's very poor recall after a delirium of what involved. People have no recall that they were as crazy as they were. Whereas near-death experiences, the memories last over time. Years later, they can be remembered for absolute detail. The after effects are so different. Delirium doesn't have much impact on the subsequent life other than to say, I don't want to have that again. Whereas in near-death experiences, there's much more intention to live with life purpose and to love others, and much less fear of dying. Now, some people say maybe it's just temporal lobe stimulation, because that, if you stimulate the temporal lobe, you can have feelings of love and expansiveness. But that doesn't explain all facets of the near-death experience, like new knowledge about people who died, or awareness of conversations or events that occurred elsewhere. And the unconscious person couldn't possibly have overheard those conversations. And these are called veridical events, if they're events that have been verified to have actually occurred. And temporal lobe stimulation doesn't explain how one can have new knowledge of past or future events. Now, Dr. Jeffrey Long has written a book called Evidence of the Afterlife, and he's what can't be explained by biological theories, 9 lines of evidence. And these counter any single biological theory. One is that the level of consciousness and alertness during a near-death experience is usually greater than in everyday life, even though the person is medically unconscious or clinically dead. That we cannot explain. Or how the person can see and hear events that were later absolutely verified by others from a great geographical distance. Or when people encounter people that are always deceased, you'd expect if it was from the subconscious, these visions would include living relatives. And what about the new knowledge about a relative that might have been imparted during the near-death experience? Another thing is that children not exposed to religious doctrine have strikingly similar experiences as older adults, and that they're consistent around the world and across different cultures. And that the after effects are so powerful and lasting. So this can't be explained by biological theories. And a 10th line of evidence now is that sometimes healthy people share some of the spiritual experiences of the dying person, such as Jeff O'Driscoll, who in the emergency physician who saw the spiritual energy of someone who was just deceased. Now, he wasn't sick, he wasn't hypoxic or septic, but he was able to share in that. And he had he saw one woman who turned and looked at him and thanked him for having tried to save her and for working on her husband, who was also ill at the time. There's a study done by William Peters looking at shared perceptions of the dying process by people who are emotionally close to the dying person. And he's developed protocols that assist couples where one person is dying, and they reinforce the connection with the couple so that when the one person dies, that they found a statistical increased likelihood of the other sharing a vision or a dream or some telepathic communication. But beyond the 9 lines of evidence, the event that was most convincing to a skeptic was to have an experience, according to Dr. Eben Alexander, the neurosurgeon who had one. So I want to move on now to practical tips for approaching the topic of dying. We can ask the hope questions, and we can say, what worries you? How do you feel? We can also say what I said, what we know from people who come as close as you can get to dying and still have survived to talk about it is that the actual moment of dying is peaceful, regardless of what it looks like on the outside. And I emphasize the difference between external observations and internal experience, like the example of the man Daniel Brinkley, who was electrocuted, which might have looked quite violent to an onlooker, and yet he described feelings of utter peacefulness inside. So whatever it looks like on the outside, we know that for the dying person, the experience feels very peaceful. This really helped a father who watched his son collapse of a heart attack in his teens and collapse. And the father was traumatized until I told him about this, and that his son was actually probably experienced peacefulness. When people are afraid, we can talk about that sometimes people have dreams of deceased loved ones arriving to welcome and escort them, as in Dr. Christopher Kerr, a hospice physician, has talked about this. So I ask, have you had dreams or visions of loved ones who have passed over coming to see you? Reinforce the elements of welcoming by loved ones and of celebrating. I'm going to move over this story. But some people, like my atheist friend said, don't dare anybody try to convert me on my deathbed. And I happened to be with her when she was dying. And so I didn't talk about near-death experiences, but I did share happy memories of evening bonfires and enjoying the beauty of the light and the happiness of being surrounded by loving friends. And I hoped that that would be a good metaphor for her to give her some sense of peace. As I mentioned in the slide, you can lead a horse to water, but you can't force it to drink. And so we can use metaphors to suggest hope. Perhaps metaphors of when the person's traveled before. How did you feel before when you went on a trip? Were you apprehensive before? Must have been hard to imagine before you were there, but what an exciting adventure you had later. We can talk about light or celebrations. Quick story of Lisa. She asked the hospital staff, what happens when we die? What is it like to die? And unfortunately, the medical staff responded literally to her question and described in clear detail the physical changes of dying. So she was terrified and was referred to me for increased anxiety. So this was an example where I told her about near-death experiences, and it totally changed the next 3 weeks from being one of terror and macabre images to hoping for a celestial reunion with her beloved uncle who'd gone on before and was a great prankster, and she was looking forward to seeing him again. We can use near-death experiences for helping people in their spiritual development to underscore the possibility of a greater purpose in life and greater context for understanding one's suffering. I say to people that, life is, in this physical realm, it's like going to school. Now, some people I deal with have suicidal ideation, and it's a dicey situation, isn't it? In providing hope for someone who's suicidal and telling them about near-death experiences. I don't want to paint it to be such a good thing on the other side that they want to hasten this whole situation along. So, but I do talk to people about what we've learned from near-death experiences to help them see that they are in a spiritual situation here. And it's important to ask if people are having suicidal ideation, and this can occur even in non-psychiatric settings or in medical wards, like the young mother with the chronic life-threatening blood condition who was battle-weary and had no purpose, who felt suicidal, or the young father who stated he would kill himself if he was told his condition was palliative. So it's always important to ask if you think someone's suicidal as well. Trust your intuition. Sometimes we don't always know, but we just get a gut feeling. So go with it. And it's not always in psychiatric settings. So, and what I say to people is it may feel as if it's hopeless, even though the reality is that it's not hopeless. It feels as if it's hopeless. I say harming oneself could be a disaster of permanent effects for what is likely a very transient situation or transient mood. But remember, if you are unsure, call 911 or have emergency involved. But I do tell patients who are suicidal, chronically suicidal, about near-death experiences, and that these accounts suggest that there is a spiritual realm, that we are known very personally and loved by a spiritual force who is aware of our circumstances and life events. Our lives do matter and have individual purpose and meaning. And loving others is most important. That's what I told the father and that mother who are sick. Your children need to know they are loved. They need you. Exiting early can send a lifelong message that they were not worth living for, that they weren't valued enough. And I say there could be possible consequences to suicide, even though I believe there's a spiritual realm. I also feel that we're here for a purpose and that we're here to learn things. And if you exit early, you might have to redo things, as one patient said, that she tried to shoot herself. She did shoot herself and she lost consciousness. And she said, wow, I learned that I could stay on the other side, but if I did, I'd have to go through all that learning again in some way. And she said, I've been through enough pain in my life. I didn't want to have to redo all that again. So, and that can be a very powerful story for people. What I also say to people is, life is like school. And, if you exit early, that's like dropping out of grade 12 2 months before graduation and then finding, oh no, now you have to start right back in grade 10. And you got so close. You don't want to have to go through all this again. So let's just, tough it out. And there's value in that. You're learning, even though it's tough. And that other people, even if people in this realm don't see how tough it is, there is a spiritual realm that it does seem that the Creator knows what you are going through. So I talked about that woman who had shot herself and her experience to my patient, Lara. And the following appointment, I asked her if she had suicidal ideation. She said, well, a bit, but boy, those comments had such an impact that she didn't dare think about acting on those suicidal thoughts. I don't want to go through all this trouble again. So there is a role in using near-death experiences with suicidal patients. And I also say, even with the terminal illness, it's important to keep going as long as you can. As one mother said to me, she had 3 little kids. Each day I can live longer is one more day my children have a mother. Boy, she was in my group. We had several mothers with young children, and I have never forgotten that, that the value of just carrying on. And even though life can be challenging, that it's important to do the best you can and tough it out. And I said, even with the terminal illness, a parent can demonstrate being a hero to the children as his or her legacy. Our actions matter. And every additional day lived might be just enough for a new drug or cure. And by the way, I also do use antidepressants to help increase resilience. So I do whatever I can. So I'm just looking at the time here, and I have a few more stories. I'm not sure if to spend another 2 or 3 minutes on Jennifer's story, or whether I should just stop at this point.
You can 2-3 minutes is okay. I think you can go on.
Okay. Well, this Jennifer was the daughter of my patient George. His 30-year-old daughter Jennifer had overdosed repeatedly with several cardiac arrests, leading to severe brain injury, seizures, and ICU. Jennifer had been adamant for years that she wanted to leave this life, and major attempts for intervention and treatment had been unsuccessful. Well, now George worried that she was suffering even more now with her severe brain injury and then prior to the overdose. And she was in ICU. She had said, "I want to die. The physical pain's always there inside me," and for years. And again, after this most recent episode, and was saying, help me, I want to go. She had fluctuating ability to communicate. The decision was made on her behalf to discontinue life supportive measurements and to have no feeding tube, as this would be consistent, as that was what Jennifer would have wanted. She would have wanted to have had a feeding tube. So the father had guilt and ambivalence about the decision to discontinue life support and for her to be moved to a hospice bed. George asked me, what should I say to her as she goes to hospice? I said, tell her how much she's loved and will always be loved in this physical life, and will be loved in the next realm. Ask her if she's had any dreams or visitors or seen others nearby to welcome her. There was no response. Tell her that leaving this body will be a relief and will be peaceful. Talk of possible celebration on the other side when she arrives. So George showered her with love for the month after the overdose, and then commented that Jennifer died peacefully, as I had hoped. George had been a conservative Protestant Christian, but was now less rigid in his beliefs. However, he still worried that she might be punished in hell for past suicide attempts or for Jennifer's decrease in faith. So what helped her grieving parents? While appreciating the complexity of grief, walking alongside as a witness to their suffering without glib attempts of reassurance. I didn't say, I know how you feel. Listening and debriefing. The patients felt overwhelmed by grief and guilt about having been angry at their daughter. We discussed anger was a natural reaction to her behaviors and realistic in the context. It was also natural to also feel guilty about the anger. Jennifer's mental illness had been subtle, confusing, and ambiguous, which made it difficult to understand or to accept her behavior. I urged compassion both for Jennifer and for themselves. I said, we're all imperfect and life is harder for some. I also said that they loved Jennifer and that the difficulties in the relationship did not erase the presence of love, and Jennifer knew in her soul that she was loved. The parents had long-standing but now ambivalent Christian beliefs, but were interested to hear what I had learned from near-death experience stories. We discussed many features of NDEs and applied them to Jennifer. She was now free from the constraints of a mentally and physically ill body. Perhaps she was enjoying new vistas and adventures and glorious colors unseen on earth. The father commented, it's helpful to consider where she might be spiritually at present. Possibly she observed and appreciated the very thoughtful tribute in her celebration of life held outside in nature. The father read at the service, remember, a grave is only a curtain for the paradise behind, by poet Rainier Maria Rilke, which responded with our discussion of the veil. What about themes of punishment in hell? We discussed concepts of earthly life as school for the soul, and that the life review in near-death experiences emphasizes a loving assessment of what was learned from the life experience on earth, rather than punishment. We talked that depression can diminish faith, and surely God wouldn't punish Jennifer for a symptom of depression. The father said, this is all very comforting. So we talked that near-death experience stories suggest that we are not alone and our struggles are not unnoticed, that God sees all. And that I said to George that when he felt isolated, lonely, and despairing, you may think that your suffering's unnoticed, but these stories suggest that your life might be actually on a stage that seems empty, but there could be several thousand souls in the audience, absolutely cheering you on, shouting, "You're doing a wonderful job, keep going." So the Father appreciated that. Why do we suffer with extreme challenges sometimes? George wondered if he was being punished. I said, our journey on earth is to experience life and to gain perspectives, as suggested by the Life Review. Perhaps George, with excessive extreme challenges, was a student in the accelerated program. This comment brought humor, acknowledgement of the degree of stress, and a new spiritual interpretation for the extreme medical challenges and family anguish in his life. And that's where I'm going to end it. So I'm open for questions, comments, or reflections. And thank you for your time and interest in listening. It's a lot of material, I know.
It is a lot of material, but I always feel so emotionally touched by your talks and the way you approach your patients and the approaches that you use. It's really impressive. But we have some questions. I think Amanda will ask some of the questions. We got some people saying that your talk's wonderful and very inspiring. So Amanda will ask you some of the questions. Then Livia also has some questions for you.
Okay, there.
Amanda?
Yes, great. So, Dr. DRYSDALE, one of the questions in the chat are, have you seen in your practice if subjects tend to have descriptions of these visitors that align with their pre-existing religious beliefs?
Sometimes people have experienced visions that were surprising to them, is what I've noticed. Or they didn't know how to interpret them. And sometimes they align with their beliefs. Sometimes they're surprised. I think the patient, prior to her transplant, wasn't expecting to see an angel. Now, had she believed in angels before? I'm not sure, but she was quite surprised to have a 7-foot angel suddenly appear at the foot of her bed without other delirious symptoms associated with it. So I think sometimes they are a feature, they're congruent with the person's beliefs, but sometimes they're a surprise, especially if a person's agnostic or atheist. Yeah.
Yeah. I think also the person asked, for example, do you see more frequently that Catholics describe the visitors as angels versus Buddhists maybe describe them a little bit more congruent with Buddhist representations?
I cannot comment on that from my experiences with patients particularly. I think people of all different religious backgrounds have experienced in near-death experiences. They've seen patients, people of light, and they tend to be deceased. But I think how they interpret the being of light might differ. Like the child thought it was Santa Claus. One child thought it was Elvis Presley, which I thought was hilarious. But actually, Elvis Presley, I think he had kind of a loving demeanor with his fans, and maybe he once reached down and smiled at that person, and that person felt a divine energy. I don't know. Some people interpret the being of light differently as God, but some people have said unmistakably Jesus was there, not necessarily Christians beforehand. So that's interesting,
Thank you. The next question is, when you have a patient that, says that they are atheist or agnostic, meaning, they have no belief in a spiritual realm or just no belief at all, or a belief in a spiritual realm but not God. How are you able to help patients in those situations where they're very adamantly against those types of religious beliefs?
Well, as I said, you got to respect people's desires. You can't force religion on them. And like that friend of mine who said, I'm not going to have anybody ram religious beliefs down my throat. Her sister was a Baptist minister. and I just it was a divine intervention that I actually happened to be with her. I think it was a fluke that I happened to be in the interior of British Columbia at the time she was dying, and her husband came knocking on my door at 7 a.m. Could I come and be with her? And she died a few hours later. And so there wasn't any way I was going to ram stuff down her throat about seeing things, but that's the one that I talked about, the bonfire. Remember all the bonfires and the nice times we had all together. So I thought, okay, that's the image of light and of love. But I had another patient who was atheist and proud of it, and she said, "I'm worried because I'm worried I'm having premonitions because I'm thinking a lot about dying." And I said, "Well, tell me about it." Well, she'd actually had during the course of her stem cell transplantation treatment, she'd had a cardiac arrest, and she said, well, I remember, and I'm thinking about this all the time, she said, I just remember sort of watching myself from the foot of my bed, and I can tell you which nurses came in and did the resuscitation and who did what. And I said, well, I don't think you're having premonitions of dying. I think you're having memories. You've already been through that, been there, done that, girl. You're alive. Now I think you need to be focusing on why you're alive, living the life you're meant to live. But it was very hard for her because she was in her early 20s, and her identity was very strong at that time as being an atheist. She was proud of it. So she didn't know how to integrate this knowledge into it. And it was kind of confusing for her. And then she didn't come back after a couple of times. So I think it was just too much of an affront to her atheist beliefs still. So you can't help everybody, and we can tell people this is what other people have experienced. Now, you may or may not accept the spiritual implications, but what we can tell you is that people got that close. It was peaceful. They come back, they say it wasn't painful, it was peaceful, and go with that.
Thank you. And since we're on the subject of the near-death experiences, should we be able to expect reports of near-death experiences every time that someone has been reported clinically dead or resuscitated? Do you feel like maybe it's just underreported, or what have you that do report that versus not?
Well, the research shows that about 18% of cardiac resuscitated patients, like in cardiology units or in emergency departments. This was research done by Dr. Pim van Lommel in Europe, a cardiologist, that 18% of patients would talk, when asked, would report that that's what they experienced. So that's what, 82%, 83% of patients have not had that experience who were resuscitated, or maybe they did, but it's lost to their memory. But most people, it seems that when people have had this experience, generally it's indelibly marked in their memory. Yeah. But they might not talk about it for fear of being diminished, or that this was such an important experience to the person. They felt that they've had a keyhole look at the universe, or at the nature of consciousness, and then to have some doctor come along, or a nurse, or say, oh, you were just septic, or that was just your morphine. They don't want it to be trivialized or diminished. So that's why people tend to keep so private about it. But if you start asking around, it is amazing how many people have had it. And the funniest was a family member of my own family. And I said, oh, do you want to hear about this talk or see this movie? And the person said, oh, I've already had my own experience. I watched my surgery from the ceiling. I said, you never told me this. He said, well, it's private. So that was a member of my extended family. But I just thought that was very funny because of all people, I would have thought I would have known or been told about this. So it just goes to show you, people do keep it very close to the heart. They don't want it to be diminished.
Got it. And then I think this is our last question, at least so far. In your experience, do you see that the near-death experiences have any correlation with the severity of illness?
Well, I guess you can't have one unless you're pretty sick to have had a cardiac arrest. But people have had near-death experiences when they haven't actually, they haven't been sick, but with impending trauma. You know, for example, a person in a car accident who felt that they exited their body and saw it before the impact and before experiencing any pain. So I guess that refutes what I just said, that some people can have it without having such a severe illness at all. But other than that, I can't really comment. You know, it's and then it gets compounded by delirium as well. So many patients in ICU can develop delirious episodes. Those are different. Or sometimes people can have a delirious episode and then they can come out of the delirium, but then they can also have a spiritual kind of experience or images and then go back into the delirium. It's complicated.
Yeah. And is there any data, that gives information about people who actually do die after having a near-death experience?
Well, we all die, and many people have had near-death experience. So I guess, but people, when they've had a near-death experience, do lose their fear of dying. And, I have had patients who've had spiritual experiences and then later have died. I had one patient who had a very long chronic illness, but seemed to be doing okay, but then had a dream of a near-death experience. He was a religious person, but he didn't know much about near-death experiences. But he said, I had the strangest dream. I dreamt, I popped out of my body and I went down this tunnel and I saw beings of light. And I'm not afraid of dying anymore. And I thought that was amazing because it was the dream equivalent of it. And he actually hadn't died. But after that, he lost his fear of dying. But it was a gift to him because he did die a couple months later. But at that time, he was no longer afraid of dying. So maybe that was a divine gift for him.
Interesting. Dr. Doi, those are all the questions.
Good. I think Livia has some questions of her own.
I have one. Dr. DRYSDALE, I'm touched by your presentation. Thank you so much.
Thank you.
Can you hear me?
It's a little bit of problem, but I'm getting it.
You mentioned in your presentation the importance of the awareness. Oh my goodness. The awareness of spirituality. But I see the lack of training of our colleagues. They are not well trained. So what is your experience on giving training to those physicians that, the healthcare professionals, because you are the outstanding physician working on that, the perfect word with your experience, 30 years experience, but that is not the reality for most of patients, right? Some of those patients, they are afraid to be stigmatized, the stigmatization from the physicians with different faiths. So that are your guidance on that, for that
Well, I've worked in various
lack of guidance
hospitals.
for the physicians.
Well, I think that's why this is so wonderful that Dr. Doi is creating these webinars to increase knowledge and understanding, and we can all do our bit in teaching about it. But it's not fully understood. And I've worked in a number of different hospitals, and this reminds me of a story that apparently this was a story by Dr. Raymond Moody, and this cardiologist stood up and said, "Well, I've never had a patient who's ever told me about this, and I've seen lots of cardiac arrests." And someone in the room said, "Well, I'm one of your patients and I've had one, but there was no way I was going to tell you about it." So this cardiologist at that point was very narrow-minded. And I will tell you that I have had to tell some patients, look, I'm very open and I'm accepting that this is a spiritual experience, but not all psychiatrists are like that. So you have to be a bit careful. Just like a parent tells a child, you want to be nice to people, but you can't trust everybody and you have to be a little bit wary. And I think that actually goes for patients too. You have to be a little bit wary sometimes with who you tell what
Mm-hmm.
and who you disclose private information or personal information to. So I will say, well, yes, maybe it's best if you and I just talk about this, but not necessarily talk about it with all of the staff here. On the other hand, we can always push the boundaries a little bit. And we each do our part in that, I think, by pushing a little bit.
Yep. Anything else, Livia? So I think on the time here, we have had so much information, Dr. Drysdale. I think this has been great. And of course, we would love to keep on hearing your stories because they are so inspiring and bring so much knowledge that we could use. So, but we are aware of time for you and for all the participants, especially those who are in Brazil, and for them it's kind of late. So
thank you everybody for being so patient and listening. I know some of it was pretty fast paced, and thank you, Margariti, and I just saw your comment, and it's very nice to talk to such an open audience and appreciative audience. So thank you. And just one more thought too about that dog that was barking. Livia, apparently people do have beloved pets come to welcome them as well on the other side.
Very nice.
So the dog wanted to have his say. Wanted to participate in this.
Okay, so
thank you for the kindness.
So
okay.
much.
And thank you for everybody for helping get this going, because it's not easy with all of this organization and screen sharing, etc. So thank you for everybody involved.
We are thankful to Sabrina and Gleison that help us to put together all the technology behind it.
Yeah.
So thank you so much. I'll be talking to you later.
Yeah.
Thank you.
Good night.
Good night.